And I am so pleased that we can move on to our plenary presentation. We, in our villages and other organizations, we're doing this because we want to help older adults age in place and remain at home safely as long as they wish. And our social activities and services are intended to help them thrive in their communities. Now, in my personal opinion, and I think most people would agree, looking forward, looking ahead, and planning for the end of life is part of living life the way we want it and how we want to leave it. So to achieve the end of life that we want, planning, instructions, and conversations with loved ones and healthcare providers are essential. For those of us like me who wish to spend our last months and days at home, they're really critical. Villages can be helpful by sharing resources and tools that can help their residents and members think through their own wishes for having the end that they want and the instructions that they need to give to their healthcare providers and loved ones to be sure that they're followed. So we are so pleased to have Kim Callinan speak with us about all of these things. Kim is president and CEO of Compassion and Choices, which is one of the leading organizations contributing resources, ideas, and tools to help people experience a more compassionate end of life. Prior to joining Compassion and Choices, Kim spent 2 decades creating integrated campaigns on social change and certainly changing attitudes and institutions and laws and practices regarding end of life is certainly a very important social change. And that is extraordinarily important experience that she brings to it. Kim has a master's degree in public policy from Georgetown, yay, and a graduate certificate in public health from the University of South Florida, and a bachelor's degree in government from Oberlin College. And she also holds a certificate in the fundamentals of gerontology through a joint program offered by the American Society on Aging and the University of Southern California, Davis School of Gerontology. So Kim, welcome.
Thank you so much for having me here today. And I just really, Mary Jo, thank you for the invitation. I have had the pleasure of speaking at various villages across the country. And I am so in awe over the work that you guys do and the community that you form. And so thank you for the opportunity to be here and for really the very innovative way that you help to support people in their communities. So thank you. Most important today is when I'm done presenting and we have some opportunity for discussion, you'll be breaking out into smaller sessions. And so I wanted to take a moment to just introduce my amazing colleagues and friends who are here today to facilitate those discussions. And so if you guys wouldn't mind taking putting your cameras on and saying a hello and a wave. Donna Smith, who will be facilitating the DC region, is with us. Donna.
Hi, good morning, everyone. Very happy to be here. Thank you for the invite.
Wendy Miner, who's facilitating the Maryland group.
Good morning, everybody. Thank you for having me.
And Tim Appleton, who will be coordinating the Virginia group.
Oh, good morning, everyone. Thank you for having me.
So they're really the most important people that you need to know today, because in addition to facilitating your group, they can serve as a point of contact for you and help connect you if you have an interest in getting more involved in this work, in this movement after the call, or just if you have your own questions about how to plan for the end. With that, I'm going to go ahead and share my screen and take us through the presentation. So, so I'm going to start off sharing a little bit about why this work is so important through my own personal experience. And this story happened long before I joined Compassion and Choices, but it was one of many reasons that I felt so strongly about this work. So over a decade ago, I got the phone call that nobody ever wants to get. My mom called quite upset. My father was being rushed in for emergency surgery. He was having a quadruple bypass surgery. And they didn't know if he was going to make it. I immediately got on a plane, flew out to Florida, arrived in the hospital just before my father was about to go into surgery. And when I arrived, he pushed a piece of paper in front of me and said, "Here, sign this." So I dutifully signed the piece of paper. I said, "What is this?" He said, "Oh, it's, the form so that you can be my healthcare proxy if anything happens." And I said, "Okay." And like a dutiful daughter, I signed the form. I handed it back to him. And he went into surgery. The surgery ended up taking several hours longer than it was supposed to. And about halfway through the surgery, I looked up at my mom and I said, "Why did Dad have me sign the form to be his healthcare proxy and not you?" And she said, "Well, because he knew I could never make the difficult decisions." And I said, "What difficult decisions?" She said, things like whether or not he would get certain treatments, or whether you would want to pull the plug, or, those kinds of things. And I said, "Well, how will I know how to make the difficult decisions?" And she said, "I don't know. He just knows you're stronger than me." And I said, "But I don't know anything about making these difficult decisions. This is like a big responsibility." And I said, "Well, what would Dad want in those situations?" And she goes, "I don't know. We never really talked about it." And I said, "So you mean Dad is in surgery now and I could have to make a difficult decision and none of us know what he would want?" And she said, "I don't know. We'll figure it out if it happens." And I said, "Well, but what would he want? This sounds really scary." So I am now getting more and more hysterical. And so I do what everybody does in the 21st century, is that I asked Google. I started Googling how to make difficult end-of-life decisions. Lo and behold, you will be not surprised to know that Google did not have any more answers than my mother had. So what I did learn as I explored through Google was that what you really want to do if you're making a difficult end-of-life decision is have a sense of what your loved one's values and priorities are before they get wheeled off into surgery. And of course, at this point for me, it was too late to do that. My story has a happy ending. My father got out of surgery. He ended up making a full recovery. He's still alive today. And we have had many, many, many conversations about what his values and priorities are since that point. What I can tell you from my experience working at Compassion and Choices is that my story is a very common one to happen. And unfortunately, many of them do not have happy endings. The person does not recover from whatever the surgery was, and that person is left in the position of having to make these difficult end-of-life decisions, never having a conversation with their loved one. And so what I've learned through that experience is that end-of-life planning really is a gift for the dying person and for those who are left behind, because it is with conversations, it is with clarity that your loved ones are able to make decisions on your behalf. So even if you yourself don't feel like you need to plan for yourself, think about that planning for the end of life as a gift you can give to your loved ones. Because Donna and Tim and Wendy and me are on the other side of distraught families every day who have never had the conversation with their loved ones about what they would want, and leaving a person having to make those agonizing decisions on your behalf with no information is really devastating. And it is a memory that is etched in people's minds long after the person dies. So what I'm going to do today is give a brief overview of what Compassion and Choices is all about, talk a little bit about the current state of end-of-life care, and talk a little bit more about how you plan for your own end of life, and then spend time answering your questions. And of course, you'll move into breakout groups. Compassion and Choices, quite simply, our mission is to improve care, expand options, and empower everyone to chart their own end-of-life journey. We take absolutely no position around what the right end-of-life care is. Some people will choose all available treatment options and they want to fight until the bitter end. Other people will choose to forego treatments so that they can have a bit more clarity at the end and not have the medication that might change their ability to relate to people. All of those options are absolutely acceptable options. We take zero position on what the choices people should make are, but what we want to do is to be sure that all people are fully empowered, have full information so that they can be thoughtful about their own end-of-life care decisions so that they can die with the kind of end of life they want and so that their loved ones can support them in a manner consistent with their values and priorities. I think a bit about the end-of-life movement as what's been taking place around the childbirth movement. And we are kind of earlier in the process and hope to realize the kind of success the childbirth movement has realized. So when my mother had me back 50 years ago, she had absolutely no say over what her childbirth experience would look like. She was rushed to the emergency room. My father was relegated to the waiting room. She was immediately given twilight medication, which kind of knocked her out. So she has very little memories of what that childbirth experience looked like. And I was born shortly after that. While, I came out and that was successful, it wasn't a patient-directed childbirth experience. It was a very medicalized experience. You fast forward 30 years to when I had my son, it was a very different childbirth experience. By the time I had my son, women and really partners, women and their partners were much more in charge of the childbirth experience, or could be should they want to be. I had a 10-page birth plan. I detailed out what my values and priorities were and what I wanted to take place. And that was what guided the medical decisions. And there was a moment during my son's childbirth experience where he was not progressing the way he wanted, and both mine and his heart rate started to drop. And I was in the hospital because while I didn't want a fully medicalized experience and I wanted a natural childbirth, I did want to be sure he was safe. So, and that if anything happened, that we were right there with medicine. That was the sort of choices that I had made at the time. And so they were getting ready to wheel me out for a vacuum extraction. And the nurse midwife who was there said, she really wants to do this naturally. Let's try one last thing. And she had me stand up and I stood up. And as soon as I stood up, his heart rate and my heart rate went back up. And she was able to reach in, take the umbilical cord out, and he was delivered naturally shortly after that. So that's an experience of the kind of transformation that took place in the childbirth movement. Because it was my values and priorities that were dictating it, while that gurney was right there waiting for me, if that had not worked, they first went with my values dictating it as long as he could be delivered safely. And that's the kind of transformation that we're trying to see in the end-of-life care movement. Moving from what we currently have, which is a very patient-centered, powerless end-of-life care, where really the patient is in the middle and everyone is making decisions about what's in the best interest of the patient and what they would want, to one that is far more patient-directed, where the patient is able to values and priorities are what's dictating the kind of care that they receive. And to be able to have that transformation and change, you need to have fully informed patients. So you need to have people like yourself who are understand what their various care options. You have to have a medical team surrounding them that understands what the options are and really is guiding caregiving based on the patient's values. You need to have laws and policies that are supportive of patient-directed care. And that is the work of Compassion and Choices and what we're currently all about. If you look at our current end-of-life care system in the United States, I would say that it's in crisis. Right now, the bend in end-of-life care is that people will end up getting all available care regardless of what their values and priorities are, unless they are a fully informed patient who is asking the right questions in order to get care that's consistent with their values and priorities. Now, of course, we all go through our lives, and what we're fighting for is the best care possible. So the question that I almost always get is, well, why wouldn't somebody want aggressive treatments at the end of life? Because it feels like what someone might want is care. And I will be 100% honest in saying that for some people, aggressive treatments are exactly what they want. But if you look at the evidence and the data and the survey data, most people, when they are aware of what aggressive treatments are, most would choose to forego treatments and balance quality of life over quantity of life. And what's not clear within our medical system is that people get full information to be able to make those informed decisions. So there's all kinds of treatment that someone might get at the end of life, and those decisions are blurry. It's not entirely clear what you might want and what you might want. So as an example, at the end of life, some people may choose to forego pain medications that make them blurry and unable to communicate and unable to have conversations, and might choose to have a little bit more discomfort in order to have clarity in conversations with their loved ones. So that might be one decision. But if someone is not active and involved in that kind of end-of-life decision-making, they may not realize that it's even an option, or that it's their medication that's causing the clarity or the hallucinations or the inability to communicate. Another example of that might be the aggressive treatments that you often get with resuscitations. You see in the media, you know, a lot of times when people are getting resuscitated on television, you don't understand the full impact that has on somebody's body. So for example, somebody who has dementia, has advanced dementia, and they end up rushed to the emergency room. For many, a feeding tube or being resuscitated so that your ribs are broken, or a tube is you're intubated, so a tube is put down your throat. Those are all very invasive. Those procedures hurt. It might be that somebody in a state of advanced dementia would not want those treatments because it's actually causing them more pain and suffering than it would be to allow them to have a natural death. So those are the kinds of end-of-life decisions that we make. And the bend in our medical system right now is to assume that in all instances, the goal of care is the extension of life. It takes having really good doctors or a very informed patient to present somebody with all options so they can make a fully informed decision. Right now, 9 out of 10 people who are 50 plus are confident they will receive the type of medical treatment they want at the end of their life. However, while 1 in 4 people who enter the ICU with a documented do not resuscitate order still get CPR, even though it's documented, they're still ending up getting CPR. And this unfortunately happened to my grandmother. And it was pretty devastating. As we were in the room and we were with her after she got the CPR and she ended up being intubated, she was so angry. And I still can remember the look on her face, feeling as if we had violated her at the very, very last moment in her life. She ended up pulling the tubes out and dying shortly after that. This was before I worked at Compassion and Choices, but my last memories with her are feeling as if I violated her and her wishes. 3 in 4 patients with advanced cancer get treatments that the professional society recognizes as harmful. So 3 in 4 patients with advanced cancer. Now, this is really important. There is many, many, many cancer treatments that are life-saving. So my message today is not don't get chemotherapy or don't get immunotherapy. There are many that are beneficial and life-saving. The challenge is in really discerning which are the ones that are beneficial and life savings and which are the ones where the likelihood of survival is small, and when they are administered to me, there is a very strong likelihood that my quality of life will significantly diminish. Because the reality is that under FDA guidelines, there is nothing that's assessing the quality of one's life and the impact a drug has. All it has to do is show that it could potentially extend your life by 2 months. But that life that's extended, and this unfortunately happened to a good friend of mine, there was zero quality of life for her. She was in so much pain and suffering. And so her very last few months, she never got to say goodbye to people. She was fighting so much to the bitter end that she lost the moments, those special moments together to say goodbye. And instead, she was drugged up and in tremendous pain that is unfathomable. But those there weren't choices that were presented to her. She simply went along with the treatment plan, desperately wanting to live. And unfortunately, it had a serious negative impact. So again, many, many, many valuable and beneficial cancer treatments. I am not suggesting you don't get treated, but asking the right questions to understand what are the benefits and the burdens of the treatments are really important, so that you understand whether or not you are receiving an experimental treatment that could have unintended negative consequences that are different from what you might want at the end of life. 3 in 4 patients with a documented preference for comfort care get at least one aggressive intervention. And 1 in 3 older adults die with Alzheimer's or another form of dementia. And those people often are getting their wishes, they're getting aggressive end-of-life care treatments at the end of life. We also know that considerable disparities exist at the end of life. Communities of color are less likely to have documented end-of-life wishes. They are also less likely to take full advantage of the benefits of hospice care. So there is, unfortunately, this sense that moving into hospice care means that you're giving up. That stigma that's associated with hospice can sometimes mean that people are not getting the full benefits that are available with hospice care. With hospice care, you get all kinds of pain management, you get symptom management, you get access to a counselors for yourself and for your loved ones. And that's now care that is available to people who are enrolled in hospice care. But what happens all too often is people find out about hospice care or find out that they have that 6-month prognosis when they are just a couple of days or months or weeks away from the end of their life. And so we're really robbing them of that full wraparound care that's available and the support systems that are available to help families during this really difficult time. The other thing that is out there, that was this incredible study that was done that is just so important to understand, is that doctors and patients have a very different view of what the word treatable means. So when patients hear the word treatable, they see that as a positive thing. It means diseases can be cured or at least contained. The assumption is that this disease will not seriously diminish the quality of their life. And even if dire news about the overall prognosis is delivered at the same time, a patient will discount it and feel as if they have good news about their treatment plan. So treatable, what does treatable mean to a doctor? What treatable means to a doctor is that it is basically a treatment can be applied to this. There is some form of medication that I can give to you. It does not mean that the treatment will succeed or that the disease will go away. It does not mean that the treatment is even likely to prolong your life. It does not mean that the treatment is not going to result in significant burdens to you, significant negative impacts on the quality of your life. It simply means that there is some form of medication that they can give to you. So that huge disparity in what doctors see as treatable and what patients see as treatable, I believe, is fundamentally at the challenges that we're facing around the end of life. So when you're in a room and you hear from a doctor that there is a treatment or that it's treatable, the very next question that you should ask of your doctor is, tell me what that means. What's my likelihood of living with this treatment? What are the side effects from this treatment? How much more time do I have left? And while often they don't have exact answers for you, they should be able to give you the data of what's happened to other people who are similar to you and in a similar situation, and be able to give you at least some sense of numbers. The sum of all of this is that it's actually quite difficult to die in our country. Unfortunately, you know, the vast majority of people would like to die like this. They want to die surrounded by their loved ones, able to have those final memories and moments together. But instead, the vast majority of people end up having a more medicalized end of life experience. And we saw with the COVID pandemic just how dire it was for people to die alone in a hospital. I mean, those were some of the hardest deaths where people never even got to say goodbye. This really speaks to the consequences that take place for the dying person and for their loved ones if people fail to plan for the end. But the good news is that you're all here today, and what that means is that you have time to plan for yourself and also encourage your loved ones to plan for themselves. One of the most important things is that you understand your rights. There are certain rights that are guaranteed to each person that's out there. The first is the right to informed consent regarding medical treatment and medications that you get. Now, many of you know that when you go into the emergency room that you end up filling out these forms, and doctors go through these very lengthy things that are all designed to try to give the person informed consent. Unfortunately, informed consent often does not come by the way where it's information that people understand. And so understand that you really do have the right to ask questions, that just because your doctor is telling you that that's what they should do, it doesn't mean it's consistent with what you would want. So you want to ask questions. I would ask your doctor, what would you do if this was you? What we often see is that the care that a doctor is recommending, they desperately want to help their patient. It's so hard for them not to be able to cure. Like, this is why they went to medical school. And so they want to be able to help you. So it's not that they're trying to mislead you. It's that they want to be able to do everything that's possible. And sometimes that makes it really difficult. You giving them permission to give all available information makes a huge difference in the kind of care that you get. You also have the right to refuse treatments and medications. So if you are nearing the end of your life, and if you are in a tremendous amount of pain, my grandfather made this choice. He was 80-something years old. He was in hospice care. He was at the end of his life. He took heart medication, and he made the decision to stop taking his heart medication so that he could relieve his suffering and end his life more peacefully. He did that with the support of hospice and medication, and that is a right that's available to every person. You also have the right to as much pain medication as you need to keep you comfortable. Now, in most states, you do not have the right to pain medication to be able to, if the goal of that pain medication is to accelerate your time of death, there are 10 states that allow that. I'll talk that in a little bit more. But regardless of, as long as the goal is not to accelerate your death, in every state, you have the right to as much pain medication as you need to keep you comfortable if you are terminally ill and at the end of your life. Often doctors are hesitant to prescribe too much pain medication. And so this is something that you will have to ask for and advocate for, but it is your right. Now, there are all kinds of end-of-life care options that are available to people. And one of the most important things about understanding what those options are is to know them, know what they're all about. So the first option that is available in many areas is palliative care. And this happens at the onset of a serious diagnosis. You do not yet have to be terminally ill. If you have dementia, if you have any kind of life-limiting disease, there is a growing field. It's about 30 or 40 years old now, called palliative care. It started out as hospital-based, although it's moving more to be community-based. And there are wonderful doctors who will help focus on your symptom management. So in addition to having a doctor who is going to cure your disease, you also may want to ask whether or not you could get a palliative care consult, and that doctor will help focus on the symptoms that are around you and bring you greater comfort. Now, when you are nearing the end of your life and you have a prognosis of 6 months or less to live, there's also what's known as hospice care that's available. Now, we managed to make things very confusing, because with hospice care, you also get palliative care, which is pain and symptom management. But that is different from the palliative care that is offered to you earlier on. The difference is with hospice is really how it's the payment mechanism, but with hospice care and a 6-month prognosis, that is more widespread because it's available through Medicare. You do want to be sure that you're taking full advantage of the wraparound care. And hospice care is like any provider. It's like any doctor you go to. They are individual. It is not one size fits all. There are hospice cares that are incredible, and there are hospice cares that is not. Just like there are doctors that are incredible and there are doctors that are not. So you want to shop around for the best hospice care to understand which one is both consistent with your values and priority, and what are the services that are offered. And I encourage people to shop around for hospice care long before you need it. So when the time comes and you're not and you need it, you know exactly where it is that you want to go. And Montgomery County has some wonderful hospice cares. DC does as well, as does Virginia. You have lots of options to choose from, and that's something that I would encourage you to start looking around for earlier. And often word of mouth is a great way to find a hospice care. Go to your friends, your neighbors, your families, and they'll be able to help you know kind of what kind of experiences they've had with hospice in your area. As I mentioned earlier, you have the right to stop or to refuse treatment. This is everything from if you have an active medical treatment for another disease, you can turn off a pacemaker, you can not take an antibiotic. Those are all decisions that you can make. And while you're healthy, of course, these aren't the decisions you would want to make, but you'd be surprised at how much pain and suffering can take place at the end of life. And you can take active control over your end of life care by choosing to forego other treatments. You can also choose to be resuscitated, chest compressions or intubation, or you can choose not to have those things. Same with mechanical ventilation, feeding tubes, and IV hydration. So if you're at the end of life and you can't feed yourself, you know, the question is, do you want to prolong your suffering by getting a feeding tube or IV hydration, or would you rather allow for a more natural death to take place? And same with mechanical ventilation. So of course, if you have the chance of those things being short-term interventions that will allow you to then get back on the road of recovery, those may be options that you want. The question is, or those are likely options that you would want. The question is, if you're already going to die, do you want to extend how long you're suffering at the end, if you're suffering, or would you like the end to come sooner by not having some of those interventions taking place? So those are things to think about, because oftentimes it's just automatic and people aren't stopping and thinking about it. You also have the right to voluntarily stop eating and drinking. Now, this is an option that sounds awful. Like, I love chocolate cake and ice cream and pizza, and the idea that I would near the end of my life and I would stop eating and drinking does not sound at all appealing to me. However, what I will say is that many people are able to use the option of voluntarily stopping and eating and drinking as they're nearing the end. You sometimes get, you're no longer hungry. It actually is painful to eat. This had happened to my grandfather. He wasn't able to eat, and so it quite naturally happened for him. Other people choose to do it earlier in a disease progression because they're watching what's taking place to in their body, and they no longer want that. You have a right to what's known as palliative sedation. Palliative sedation is if you are in so much pain that the suffering has become too much, they can give you enough pain medication so that you are no longer conscious, and then they take away food and nutrition until you and other treatments until you die. And my father-in-law chose this option, and it can be a very peaceful end, and it is something to consider if the pain that you're experiencing is really great. And then in 10 jurisdictions and Washington, D.C., you have the option of medical aid in dying. In the D.C., Virginia, and Maryland area, D.C. is the only one that's authorized this right now. But it is the option to request from your doctor a prescription medication that allows you to end your suffering and if it's too great. There is about a 13-step process to get through it. It is not easy to get through. If this is an option that you want, you have to start it relatively early, but it does allow a patient to be able to decide how much suffering is too much for them. And that's an option that a very small number of people will choose, but for those who want it, it's an important option that's available to them. We also know that those people who take the prescription medication get tremendous peace of mind simply having it. About a third never actually use it, but knowing that they are in charge of their end-of-life experience brings them comfort. In terms of consumer empowerment, there are several things that you can do in advance, long before as you're planning for the end. The first is to fill out your advance directive. One of the most important things that you'll do when you're filling out an advance directive, and an advance directive comes into play when you can no longer speak for yourself. So it's a very small portion of the time, but it's important. It's the very, very end when you can no longer speak for yourself. That's when you want to think about who your healthcare proxy is. Who's that person that you trust to speak on your own behalf? In the story I told earlier about my father, you'll notice he had selected me as his healthcare proxy. And he chose me instead of my mother in that moment because he felt like that burden on my mother would be too great as she was suffering herself around his loss. But you want to really think about who is that person who knows you better than anybody else, who's going to be capable of making those decisions and who's going to advocate for you above everything else. You want someone who is strong, someone who's able to speak up to power, who will represent you. That might be your spouse, but it may not be. It might be a friend. It may be a sibling. It might be your daughter. It could be any of those things, but think a little bit about who it is that you trust to speak on your behalf, who has a strong enough constitution that they are going to ask the right questions and speak truth to power. You also should think about whether or not you want a do not resuscitate order as a part of that advance directive. Now, the decision that you make is likely to be different depending on where you are in terms of your health. The likelihood that you will pop out and be resuscitated if you have life-limiting health diseases is fairly small. You want to talk to your doctor about what those percentages are for yourself, and not only what the percentages that you'll live, but what's the percentage that you're going to live with the kind of quality of life that's consistent with what it is that you would want. Because some people are able to be resuscitated, but they're on a ventilator then for the remaining days of their life. So if that's not what you would want, you want to ask all of those questions of your doctor. So right now, as an example for myself, I do have it that I would be resuscitated because I'm relatively healthy and there's a chance that I could emerge from that. However, as I get older in my life, I will likely change the decisions that I make. If I were to have dementia, I would definitely not want to be resuscitated. If I were in the late stages of cancer, I would definitely not want to be resuscitated because that would be trauma that I would be inflicting on myself that is likely to have a negative outcome. But those are decisions that each person has to make, both based on where they are in their life cycle, as well as what their own values and priorities are. If you have a serious or a life-limiting disease like dementia, or if you have an advanced stage disease, you also want to talk to your doctor about having a MOST, or in some areas it's called a POST, a portable medical order. This goes along with an advanced directive, but it's actually a doctor's order about what kind of treatment you will and you won't want. You can only have a MOST or a POST if you have some type of a life-limiting disease and you're farther along in your disease. So it's not something that like I could go get right now. However, it carries more weight than an advanced directive does. And so if you're in those situations, it's really important that you talk to your doctor about it so that your wishes, it will increase the likelihood that your wishes will be honored. And then the last thing that I would say is the attitude and the knowledge that you bring forward and that your healthcare proxy brings forward is one of the most important things that you can have at the end of life. If you're clear about your values and your priorities, and your healthcare proxy is clear about your values and priorities, the likelihood that you're going to have the kind of end of life experience that you want increases exponentially. And so it is that attitude and knowledge that we hope people walk away from during this call. In terms of compassion and choices, we focus really on creating, as I said early on, an environment where all people are fully empowered to have the kind of end of life experience that they want. And therefore, we have kind of a pathway to change that of how we go about doing this. We do education to try to help people become personal advocates, like what we're doing on this call today. We focus on system reform so that we try to have more health systems and hospitals focusing on the importance of respecting the patient's values and priorities. That speaks to the kind of transformation you've seen in the childbirth movement from patient-centered to patient-directed that we're trying to work on. We do litigation, and so we will take on court cases where people's rights aren't being honored. So earlier on, I shared with you that slide that said, know your rights. If you get into a situation where one of those rights is not being respected or honored, those are the kinds of cases that we take on with the goal of both helping our individual client as well as changing the health system to making it more patient-directed. We also do some work around regulatory reform at the federal and some state levels, and we do legislative advocacy as well. So that's an example of all of the various different ways that we see change happening at the end of life. But ultimately, the reason and the goal for all of that change is that so people can have the kind of end of life experience that they want. And I'm going to share the story of my father-in-law because he really is an example of how an informed and empowered consumer can have an end-of-life experience that's consistent with their values and priorities, regardless of where they live. My father-in-law lived in Louisiana, and about 3 months after I joined Compassion and Choices, we unfortunately got the news that he had stomach cancer and he had gone in for surgery. It was supposed to be a relatively easy surgery. And it turned out that he had a tumor that was the size of a basketball that, well, maybe a basketball is an overstatement, but it was a huge tumor in his stomach and there was nothing they could do. They closed him up, and while we thought the surgery was going to be relatively easy, when he came out of it, we were told he had 3 days left to live. This was obviously just an awful news for us. 3 days does not give a person a lot of time to plan or to think about what they want. But my father-in-law was an empowered consumer. He had given thought to what he wanted at the end of life long before this moment. And his health had been declining for quite some time at that point. So while he expected to go into that surgery and to come out of it alive, he had gotten that stomach cancer diagnosis 4 or 5 months earlier and hadn't been feeling well all along. And he knew that he could tell from his body that things weren't going well. So behind the scenes, he was planning. He had actually done his whole memorial service of what he had wanted, and he had given a lot of thought around kind of how he wanted to close the final chapter of his life. He was a very proud man who was always in charge of everything. He was strong-willed. And so he clear about how he wanted to spend his final moments. At one point during the end, we were fortunate in that in about a week, we had planned for him his birthday party. He was about to turn 80. And so we were all coming into town for that, but it wasn't clear if he was going to make it in time for that. Fortunately, he was able to hang in there. He got a chance to say goodbye to about 80 of his closest friends. At one point, relatives came in. It's called the swoopers. It's quite common, and tried to convince him that we should fly him to Anderson Cancer Center so that he could try that one last experimental treatment. And he was very clear. He said, my time has come. God is calling me. He has a different plan for me. I know that I have a limited time left, and I want to spend that limited time saying goodbye to my loved ones. And that is exactly what he did. Each of us got our own special story. He shared with us his special tailored life lesson for each of us. One of my husband's life lessons was that I was a rare gem, and that he should treasure me. And so I was very thankful to my father-in-law for that. Every time my husband and I get into a fight, I remind him of his father's final life lesson to him. But it was a really special and meaningful time. He had this amazing birthday, and then he was able to say goodbye to everybody, and he died peacefully. He ended up using palliative sedation as his option, and he was comfortable until the end. He died with my husband by his side, which was exactly what he wanted. That is an example of the kind of end-of-life experience that an informed, educated, empowered consumer can have. And it's why I do the work that I do, and I hope that something that I have said today will have a light bulb for you, so that you can have the kind of end-of-life experience that's consistent with what you want. We have a whole host of materials. I know that Wendy pulled them together. They were posted in the chat box. Some of you came in later, so if you aren't able to see the resources that we have available to you in the chat box, please let us know and we can repost it in there again. But I really encourage you to check out those materials. In addition to filling out your advance directive, I will say filling out your state advance directive form is just not enough. We have an amazing guide called your End of Life Toolkit that is really, really important. And I'm sure that Wendy and Tim and Donna are going to talk more about this during your breakout sessions, but you definitely want to take time to fill that out. There's a sheet in there that talks about what your values and priorities are around quality of life. That will help you to understand what it is that you want, and it will help your healthcare proxy and your loved ones understand. We also have a very powerful tool called the Dementia Values and Priorities tool that helps you to identify what kind of care you would want should you end up in the unfortunate position of getting a dementia diagnosis. What is so hard about dementia, and I had a grandmother who had dementia, is that from the moment you get that diagnosis, there can be many, many, many years that you live a quality of life that is wonderful. So the a dementia diagnosis does not immediately mean your life is over. You have much more life in many instances that is meaningful and of quality. But for most people, there does hit a point within a dementia diagnosis where the quality of life has gotten so poor that it's no longer meaningful. That tool will help you to discern what that moment is for you. And it will allow your healthcare proxy to be able to make informed and empowered decisions. So I encourage you, I know sometimes it's easy to allow everything else to come before planning for the end. But I hope that something that I have said today inspires you not just to fill out the state advance directive forms, but to really become an empowered and informed consumer and fill out our end-of-life planning guide and our dementia values and priorities tool and have conversations with your healthcare proxy and your loved ones, because that is what will ensure that you have the kind of end-of-life experience that's consistent with your values and priorities, and it truly will be a gift to your loved ones. We also encourage you, for any of you who would like to follow us on social, you can also go on our website and sign up to be on our email distribution list. And I just want to thank you for the opportunity to be here today. It really is my honor. And I hope something that I have said has left a lasting and positive impact on you. With that, I will open things up for questions that people might have.
And Kim, I would like to say, it's Mary Jo, that the list of resources has been posted 3 different times in the chat, including twice toward the very end. So I hope people can go it there. I would like to actually exercise a little bit of the chair's prerogative, if you don't mind.
Sure.
I have a couple of very related questions. First of all, in your early slide, you point out the number of times that people with a DNR or people who have advanced cancer, other scenarios like that, where their express wishes are not followed. I'd like you to, and you always just said patients with these conditions. Obviously, this is more common in a hospital, but I'd like to hear from you whether care delivered just in the context of your ongoing communications, with the doctor, you're not yet hospitalized. Do those occurrences of ignoring express wishes happen even, outside of a hospital?
That's a great question. Let me go back to the hospital first to add some clarity on why it happens so people understand that, and then I'll answer the outside of the hospital. So it happens for a whole host of reasons. And I wanted to really say that I am in no way, I think our medical care is wonderful and doctors are wonderful. So I don't want to make it sound like I'm in any way being negative towards the health system. It happens for a whole host of reasons. In the case of my grandmother, it happened because they didn't have her advance directive on file. So we don't have a portable electronic medical record. So you could arrive at the hospital and they don't actually understand that that's your express wishes. So that may be one reason it happens. It may happen, and that's often the reason it happens. So, we encourage people to keep the advance directives home. It's not helpful if it's an illegal document that you filled out. It may happen because somebody calls 911 and the 911 operators arrive at the house and they don't have it. So there's a whole host of reasons that it can happen, some of which is simply that people aren't aware of your values or priorities. Your healthcare proxy may not be right with you when it happens. Sometimes it does happen because you arrive and if you go into, as an example, a facility that has ethical and religious directives, your stated wishes could be different than those ethical and religious directives that are guiding care decisions. And so it could also happen because of that. So there's a whole host of reasons. It could be that the doctor's perception is different. There's a whole host of reasons. You can safeguard yourself by filling your forms out, making sure everyone around you knows what it is that you want, and having things handy with you on you. Some people have medical alert bracelets that say what they want. If you have a local hospital, you want to call that hospital up and make sure you're giving them your advance directive directly. You want to make sure your doctor has it. So all of those things reduce the likelihood that that happens even within a hospital. When you're talking about your stated wishes outside of the hospital, the answer is yes, those could not be honored. The wishes, though, are likely different. So there's the invasive treatments that you get at the very end of life that are only really administered in a hospital setting. So that's, you know, like you're not going to be resuscitated by and large outside of a hospital. I guess there are some areas where there are things up on walls, but or if you call 911 and the ER comes, yes, like, you know, emergency personnel, you know, they're there to save you. And so if you call 911, yeah, the likelihood is that it may not be honored unless you have the form right there filled out, you know, all of those kinds of things. But in your day-to-day care with your doctor, is there a chance that your doctor might not honor your wishes? The answer is also yes, depending on what your wishes are. So I'll give a couple of scenarios of this. If you live in Washington, D.C., and you want the option of medical aid in dying, which I talked about earlier, you're really going to want to find a doctor in advance that's willing to support you. It's a relatively new practice, and there are many, many doctors that are not yet comfortable supporting their patients with that option. So that would be important. Some people who get advanced dementia or who have ALS as an example, they want to choose the option of voluntarily stopping eating and drinking earlier in their disease progression while they're still mentally capable. There are doctors who may not honor that. So again, we have this great card. I don't know if it's in one of the things that Wendy has given us. If it's not there, we can find it and linked it in, but it's how to find a partner doctor. It's a great tool. We encourage you to find that partner doctor in advance using that tool. That will help to limit the likelihood that the doctor won't support you. Some doctors won't, even though you aren't required to get treatment. Some doctors won't take a pacemaker out, as an example. So my grandfather's doctor was willing to do it. He was on hospice care. He did it without an issue. We have had other patients come to us and say that their doctors would not do that. So the answer is yes. There are other examples of where a doctor may not honor your values and priorities. And that's why it's really important that you interview your doctor even now about what you might be interested in, so that when the time comes, you get care that's consistent with your values and priorities.
My related comment was that there is fortunately an increasing movement among health professionals and policymakers toward care at home and to moving even end-of-life care at home outside of hospice, and they're calling it hospital at home. And recently, Kaiser and Mayo and about 15, 20 other of the primary providers have all linked arms to say we're going to increasingly move hospital care to the home. And I raised it because it is certainly a great step forward, but given the fact that hospitalists are more inclined to ignore your wishes, why it'll be very important, but easier for you to have at home the documentation that you need to be able to defend yourself. So we can take other, I didn't mean to.
And let me just make one comment on that. That's a really great observation, Mary Jo. You're absolutely right. And I will say it is, I'm always a silver lining on the other side. If there's one positive thing that's come out of COVID, it has been a move towards more at-home care and a recognition that the burden of having to go to a doctor's office for 10 doctor's appointment at the end of life that are not necessary, that could be delivered via telehealth is problematic. So I think part of that shift towards at-home care has come as a result of COVID. And it's one of the few positive things that's come out of this devastating couple of years.
Good. Okay, there was one question that I saw in the chat that I think you had answered already, that the case of advanced directives that aren't being adhered to by professionals. And again, I'm going to assume that that actually was answered. Let's see, we have, well, going. So are there any hands up? I was looking at the chat. I'm trying to monitor the chat, and any hands? Or speak up, since you may not all show up in the gallery at the same time.
It looks like Bob from Mount Pleasant has his hand up.
Okay, Bob.
Yes, thank you. When you introduced Kim, you said Compassionate Choices is one of the leading groups in helping medical aid and dying, but my opinion is it's the number one group in the country that is doing that. I live in Washington, D.C., and I'm very grateful for all of the work that they have done and continue to do. And I've done some volunteer work for them, et cetera. I'm glad they're talking to the villages because they're really in the forefront. A couple of quick questions. I've been talking to a company that does visual video advanced directives. And they say that there's more chance that your advanced directive will be listened to if you actually have a sign that you have a video advanced directive in which you give all, in which you're not relying on somebody else, you're doing it yourself. I wonder if you have any information on that. And also, secondly, there's a big movement on use of psychedelics in end-of-life care. And I'm wondering if Compassionate Choices has any position on that.
Those are two great questions, Bob, and thank you for the acknowledgement on our work. So in terms of video, and I should have said this is a great point, we do encourage people to have a video. It is at the end of life, it's not uncommon. I mentioned the sort of swoopers come in and they have a different perspective. They're often family members that haven't been very involved. And they feel like now it's their time to save their loved one. And so if you have that video advance directive there, it does help provide clarity for the non-immediate emergency decisions. Obviously, no one's going to be able to pull out the video if you're in that life moment. But if someone is, has some type of a treatment and someone leaves a video, it helps to create greater clarity. So we are encouraging people to do this more. It's a bit untested. So, what my attorney says is, listen, if I was in a court and I'm arguing for one of our cases that we take on and somebody has a video of their loved one, it will, I believe it will carry a lot more weight than that person saying we've had these conversations and this is what the loved one would want. So it seems very logical and it doesn't take very much time to do it. I mean, everyone's got, not everyone, but most people have videos on their phones now. So I would encourage people to go ahead and do that. And in particular, around dementia, that's really important as well. Around psychedelics, you're right, this is a growing area. We're actually studying this right now. We don't have a formal position on it. In general, we are supportive of anything that is going to result in people having a better end-of-life experience. The data that I have looked at does suggest that psychedelics are being used more to help relieve suffering at the end of life. And, I certainly think it's something that, if you're there, you should explore. There are some legal issues around the use of them that we're starting to explore now to see whether we should or shouldn't be doing more advocacy around it. But certainly would encourage you to explore it. I know some really, really very well-respected palliative care doctors who really believe that the psychedelics are going to transform the kind of end-of-life care experience people want and relieve some of the existential suffering that's taking place.
Thank you.
Great questions, Bob.
And by the way, my doctor, I have a great doctor I've had for 30 years, but he doesn't believe in this, as you said earlier. Do you provide information on MAID-friendly doctors?
So we don't publish a list of doctors that are available, but we do have a list, and in your small groups, they can, especially in the DC group, they could give you this of what health systems and hospices are supportive. Part of what we're working to do, and Bob, you sound like you would be an excellent person to help champion this, is we're trying to get people to go and put pressure on their health systems in order to adopt supportive policies and to have conversations with doctors to get them to understand why this is important, which opens up access for patients. If someone is terminally ill and at the very end of their life and is having difficulty finding a doctor, we'll help them navigate that, but we don't want to publish the list, because all you'll ever end up with is first of all, it could be dangerous for the 1 or 2 doctors, but in addition to that, you'll only end up with 1 or 2 doctors. So in our experience in Oregon, by focusing on trying to get people who want the option to convince doctors that they should support patients, we open up the practice and make it far more accessible for everybody. So if you're interested in that, Bob, I think it is Donna who's doing the DC group, and she's very involved in trying to open things up in DC, and would love your support with that, I'm sure.
Thank you.
Any other questions? I put information in the chat about the Multidisciplinary Association for Psychedelic Studies, which is the scientific organization that has been behind all the clinical trials on psychedelics. And it's a very serious organization. They have, in fact, the FDA asked them to fast track one of their psychedelic drugs for PTSD. And so this is it is becoming a perfectly respectable science-based field of study. And if you're interested, you can go to this organization whose link I put in the chat room.
Yeah, and I'll just add, it was Thursday, or I think it was Thursday, Endwell did a whole conference on psychedelic drugs. I am sure that they will, I'm not sure, but I imagine that they will have it published. Melissa Etheridge was there, and they had a bunch of others as well. So if that's a topic that you're interested in, that's also a good resource.
Okay, any other questions? Well, thank you so much, Kim. You've given us so much to think about, but more important, I think you've pointed to tools and resources to help us live our lives to the end that we wish for.